Is going to be presenting outcomes of an FFRCT diagnostic strategy versus usual care in suspected coronary artery disease, results from the platform trial. Dr. Douglas.
Great, thank you. I also want to note that in your program it lists us as the Meet the Trialist session, but we are also the first session at the 1630 late-breaking hotline trials. It's my pleasure to present the platform trial, which is clinical outcomes of fractional flow reserve derived from computed tomography, FFRCT, guided diagnostic strategies versus usual care in patients with suspected coronary artery disease. This study was funded by HeartFlow, for which I had research contracts. The optimal evaluation of new onset stable chest pain is uncertain. Ideally, testing will clarify the diagnosis and direct subsequent care while maximizing efficiency and safety. The recently presented PROMISE and Scott Hart randomized trials compared anatomic and functional strategies to the assessment of stable chest pain, finding that CT angiography improved processes of care. However, it also increased rates of invasive catheterization and revascularization with no significant reduction in clinical events. Fractional flow reserve can be derived from CT angiography using computational fluid dynamics and big data machine learning techniques. It may address these limitations by providing non-invasively both functional and anatomic data. Accordingly, the aim of the platform study was to determine whether use of a CT-FFR guided strategy as compared to usual care would reduce the rate of invasive angiography that show no obstructive coronary artery disease without increasing the occurrence of major cardiac events. This is the design of the study. Eligible patients are those with stable coronary artery disease symptoms with a planned either non-invasive test or a planned invasive catheterization in two separate cohorts. The planned invasive catheterization, shown on the right here with the yellow border, represented the primary endpoint. All patients were older than 18, had no prior history of coronary artery disease, and had an intermediate pretest probability of coronary artery disease. This was a non-randomized study with sequential cohorts receiving either standard care, shown in orange, in this case invasive catheterization, or substituting a CT-FFR-CT as the next step in a diagnostic workup. They underwent a CT, and if it showed stenosis greater than 30%, then they underwent the FFR computational process. In both the planned non-invasive and invasive arms, all testing and catheterizations were performed and interpreted locally at the site, with the exception of the FFR determination, which was performed centrally and delivered in most cases within 24 hours. All follow-up testing and management decisions by the care team followed usual best practices. The primary endpoint was catheterization, which did not show obstructive coronary artery disease, as determined by central QCA or analysis or invasive fractional flow reserve at 90 days. And secondary endpoints are those of safety with major adverse cardiac events and radiation exposures. Costs and quality of life will be reported separately. This is the primary endpoint result in the planned invasive catheterization group. As you can see in the stacked bar, 73% of those in the usual care group had angiograms which did not show obstructive disease, while under 30% obviously had obstructive disease. However, in the FFRCT guided population, 61% of invasive angiograms were canceled following receipt of the information derived from CT-FFR, leaving just 12% proceeding to the catheterization lab who had angiograms which did not show obstructive disease. Obstructive disease was also found in about 30% of the cohort. This was highly significant and robust to multiple sensitivity analyses, as shown here. Safety endpoints and data at revascularization were very rare in both groups. There were 2 MACE endpoints in the FFRCT group, one a peri-procedural MI and the other unstable angina while awaiting a scheduled catheterization. Radiation exposure was similar in the 2 ICA arms, but slightly higher in the planned non-invasive tests. Functional data were available at revascularization virtually all patients in the planned non-invasive test group. As you can see, the rate of revascularization was similar in the planned invasive test group, and functional and anatomic data were available in nearly all of the FFRCT group, compared to just half of the usual care group. In summary, platform enrolled a symptomatic intermediate risk population for whom testing is currently recommended. Use of CT followed by FFR calculations in patients with planned invasive catheterization was associated with a dramatic reduction in the rate of finding no obstructive disease at invasive catheterization from 73% down to 12%. This was a similar result was found in all subgroups, and there were no differences in adverse events, radiation, or revascularization rates. In addition, use of FFRCT resulted in cancellation of 61% of invasive angiographies and doubled the availability of functional data at the time of revascularization. Thus, in conclusion, use of a combined non-invasive anatomic and functional strategy employing CT-FFR was safe and improved patient selection for invasive catheterization. Thank you.
Thank you, Dr. Douglas. A question from there. You've got it now.
Okay, thank you. Hi, I'm Peggy Peck, and I'm with MedPage Today. And I'm wondering, given this dramatic reduction in catheterizations, do you have any data on the impact on cost? It would seem to me that there would also have been, there would have been a benefit here in saving money as well.
Well, thank you for that question. It's obviously a terribly important question in this very large population. The cost data will be presented as a late-breaking session at TCT next month, but obviously there is considerably less invasive investigations excuse me, I'm sorry, I'm speaking to the questioner. Considerably less invasive investigations. So the processes of care are quite different.
And if you can, give me just the cost of this technology, like if you have any estimate of that.
There is no, at this point, cost for the technology. It's relatively new, so there's not a good comparator.
Larry, who stood at the back.
Larry Houston. I'd love to get from you, but also from any of the panel members, how they think this might actually work in clinical practice. Is this something likely to be accepted? Are the interventional cardiologists happy or not happy about this? What does it take? Is this just you push a button on when you're doing a CT angiogram and you get this also, or what's involved with acquiring this extra information?
Okay, there's a couple of questions there. I'll start with the technical question first. HeartFlow, which is the algorithms that are done here, requires an FTP of the CT images, and they're computed overnight using the supercomputers that are available to HeartFlow that are customized with actually quite sophisticated computer machine learning to calculate these algorithms. It's a 3D modeling of hyperemia that expresses the numbers as they would be for invasive FFR. In terms of, I'm forgetting the beginning question. Oh, interventionalists, how do interventionalists feel about this? Well, the interventional community is extremely concerned, or the invasive community, with the very high rates of not finding obstructive disease at angiography. And there have been numerous large population studies. We've published 2 from NCDR with hundreds of thousands of patients that show that more than half of patients undergoing invasive procedures do not have obstructive disease. And so that becomes a really important quality of care issue. If there's a way to find a technique that increases that cath yield, that decreases the rate of those unnecessary procedures, and is safe and efficient, then I would say that would be something that would be very welcomed. I'd also say, although I'm not an interventionalist myself, most interventionalists want to do interventions. And if they're spending their day doing diagnostic caths on patients that don't have obstructive disease, there's not a lot of interventions happening during that day.
Just while we're waiting for the next question, Dr. Douglas, if I can ask you, the audience will want to know what the long-term sequelae were amongst those with cancelled invasive tests.
That's an excellent question. To 90 days, there were no adverse events at all. The trial is continuing and follow-up is continuing for 12 months.
Yes, thanks.
This is Lynn Peterson with Trends in Medicine. I'd sort of like to restate what I think was Larry's question to the panel. How interested are you in adopting this?
How interested are you in what?
And how complicated would it be for you to do this at your hospital?
Okay, so let me turn first of all to Professor Cyrus.
Yeah, I think that the type of medicine that we are talking here is about the telemedicine. So it's certainly something new for many of us. I mean, you will have to put your data on a cloud, yes, which is circulating somewhere above our heads, and then it will be analyzed in one place, and you will have to pay for this technical development, and then in a few hours, ideally a short time, you will get the answer, which is a very simple coded card system and answer. So we have to see how the community is going to adopt that technology.
Marco, do you have a different view?
No, I agree. As interventional cardiology, I would be very happy to see this technology coming through because, as Professor Douglas was alluding to, we would like to do intervention, not angiography.
Professor Kimura?
Yes, in Japan, non-invasive imaging using CT, MSCT is very common, and we are still doing invasive caths without significant obstructive disease. So I think that this technology will improve the patient care significantly.
Uwe, do you want to add anything?
Yeah, the main question is, can we perform this on a broad basis, not only in specialized centers, but in all of the hospitals? Then it's really attractive and can reduce the number of unnecessary invasive procedures, but it has to be quite easy.
Okay, thank you. So if there aren't any other burning questions, please can we go to